Hello, everyone, and welcome to Learning Decoded, where learning is made simpler and easier for you. I want you to pause and try to imagine this. It's your first day in a psychiatric hospital. Your supervisor looks at you and says, "The patient has poor insight, partial judgment, possible psychotic features, rule out bipolar disorder, conduct a risk assessment, formulate the case, and discuss differential diagnosis." Ah, everyone around you starts nodding. The psychiatrist understands, psychologists understand, nurses understand, and you're sitting there wondering what just happened. If you have ever feared looking unprepared during your internship, this video is for you. Today I'm going to teach you the practical clinical terminology that psychologists, psychiatrists, counselors, therapists, nurses, and supervisors actually use in hospitals and clinics every day where you're planning to work as an internee of psychology. By the end of this video, you will understand our 100 essential terms and you will feel far more confident entering your first clinical practice. Alright, so as you can see here that today's topic is survival guide for psychology students, useful practical terminologies. One of the biggest shocks psychology students face is not the clients, it's the language. Universities teach theories, hospitals speak terminology, and that gap actually is quite complicated. And here in this video, I'm trying to fill it up a little to support you and help you and make it a little easier for you in your practical journey or your first day in your internship. And if through this video you understand that language, then it's less likely that you will feel lost from day one. All right. So I have different categories that I am gonna talk about terminology. So the first category that I'm covering is mental status examination. The first terminology is mood. Mood is the patient's sustained emotional state. It's different from emotions. It's like emotions are temporary, but mood is a sustained state. For example, I feel sad all day. We sometimes confuse mood with affect. Affect is the expression that comes to your face. Both are related to emotions. One is the behavioral, noticeable, observable thing. The other is a sustained state inside. All right, the second terminology is affect again that are already explained that it's also related to emotions, but it's the observed emotional expression. And patient usually reports sadness, but maybe smiling continuously. It's like the affect is different than the feeling that's experienced, the emotion that's experienced. So the experience is mood. For example, a patient says, "I'm sad," but they are smiling, they're laughing. So that is definitely the different feature, that their affect is different, but their mood is that they're sad. Third one is insight. It's awareness of one's condition. For example, patient acknowledges symptoms and need for treatment. It's like if I have insight, and if I am going through depression, I have insight that, oh, I have some kind of problem, I overthink, I sleep less, I eat less, and all that. That means this is my insight and I am aware of it. So assuming insight as intelligence is very wrong. It's like sometimes literate, educated, highly professional people can also be lacking insight for their disorder. So never assume insight based on how a person looks or based on their education or their literacy, because insight can also be present in a patient who's not well off in terms of education or in terms of other aspects. So insight is when a patient, or more specifically, more clearly, I would prefer to call them a client. A client actually acknowledges their symptoms and their need for treatment, that I need treatment. So that's their insight. Fourth one is judgment. Judgment is the ability to make appropriate decisions. Patient understands consequences of risky action, and they judge, like it. Judgment is like they're able to understand what will happen, what kind. For example, if I will do something, or if some person is OCD, they have OCD. They know what is being caused. Like they have insight, they know that they have some problem, and then they also know that it is causing some kind of distress or some kind of problem in their life. So that's their judgment about it. Orientation. Orientation is, now, how do we use these terminologies? When we are describing about the patient, we need to know what their mood is, and we usually maintain their record, their mental state examination almost in every session. So these are the things that come under mental state examination: mood, affect, insight, judgment. Orientation. Orientation is the awareness of person, place, time, and situation. If you have gone through mental state examination short form, or there is a long examination as well, but the short form usually contains questions like, can you read numbers from 1 to 10 or 10 to 1, or can you tell me where you are, what date today is, and etc. So this actually helps you to assess the patient's orientation, if they are oriented to the present moment or not, if they are connected to the present place, time, and situation or not. Next. All right. So next section. Now this was the mental state examination that you do in every session, and that you have to keep record of whenever you take a session. Like if you're an internee and you're not allowed for taking direct sessions, you can simply use for your own record, that for your report writing, that will be useful for later in a submission of your project or your internship reports. Second section that I want to cover after mental state examination is the psychiatric terminology. Now, whenever we work, especially when you work in a clinical setting instead of a hospital, so you will more likely experience interaction with a psychiatrist or with MBBS doctor or with anyone who is taking care of the medications of the patient. And they definitely use terminology that you need to be aware of, because while working in a team, you cannot say, oh, I'm just a psychologist, so I don't know what you're talking about. Professionally, you need to know and understand, to connect with others, to understand each thing that other practitioners know about that patient. So the first terminology that is similar to psychological terms as well, and you must have gone through or read somewhere in your DSM, that's psychosis. So it's the loss of contact with reality. It's like believing secret agency control your thoughts, or any kind of beliefs that are detaching you from reality. So it's the detachment or the loss of contact from reality. And the mistake that usually we do, or internees do, is that we think that psychosis equals schizophrenia. No, psychosis can be a normal state as well. Like, for instance, if I'm sitting in a classroom and I had a stressful morning, and I am not in the present moment in the classroom, rather, I'm lost in my thoughts, and I'm somewhere feeling or experiencing the same thing I experienced in the morning, somewhere where I'm trying to relive that moment in my mind. So again, I'm detached with reality, and if my friend is gonna be like, oh, what are you doing, or what did the teacher say, and I would be like, oh, I had an argument with someone, because I was there in the other situation in the other moment. So I was just trying to explain that psychosis could be as usual or as common as it can be. So it's not always schizophrenia, because misdiagnosis happens when you notice, oh, this person seemed like in a state of psychosis, detached from reality. So, oh, it's probably schizophrenia. So one simple feature cannot make a label for a person, or cannot help you to decide a full diagnosis with that person. All right. I tried. I was thinking to keep today's video short, but I think I am going in details again. But they are useful for you, and it will help you to actually fit in, and it will help you to transfer your bookish knowledge to your practical life. Second is delusion. Again, you must have heard about this one already too. It's your fixed false belief despite evidence. If a person is like, a fairy follows me every day, and the patient is like, fairy follows me every day, and you show them camera proof, oh, there is no fairy behind you, but even despite of the evidence, they don't believe, then they just believe what they have in their mind. That's their delusion. Next is, we usually confuse delusion with suspicion. We think, oh, if they still think, maybe they are suspicious or something. But no, delusion is a false belief even when you try to prove it with a very logical proof. While suspicion can be removed if someone says, oh, someone follows me every day, and that's their suspicion, not delusion. In that case, you can prove them, oh, nobody follows you, and then they will believe you, because that's just suspicion, not delusion. All right, this one you must have heard already as well. Hallucination. So it's the perception without stimulus. It's like hearing voices when you're alone. There is no person in the room, nobody in the house, but you still hear voices. There is no stimuli, but there is a perception of that stimuli. Uh, I'm assuming that you already know what stimuli and perception is. If you don't know, you can Google, and that will actually help. All right. So, can we usually confuse hallucination with intrusive thoughts? Intrusive thoughts are something that we experience in OCD, something patients experience in OCD. It's like repeated thoughts that come over and over and over. While this one is the real experience of a stimuli that was not there. For example, seeing a ghost in front of you, when there is no ghost in real. So that's different from the intrusive thoughts. Next is mania. I know these ones are not very unique terms, but my explanation would probably help you to kind of remove the misconceptions that you have associated, or if not, even not, it will elaborate you to understand these terms even more. All right, mania. Mania is the elevated mood, energy, or reduced sleep. It's like sleeping 2 hours and feeling energetic. Uh, Sometimes we can think that happiness is equal to mania. We are overexcited and we are so happy. That's why we are energetic even without filling our basic need. But I know, and I have experienced as well, that even when you're overexcited, you cannot survive 36 hours without resting, and that actually, those 36 hours that you will survive no sleep for your exam period will actually make you very drowsy when you are free to sleep. But manics don't feel the need or desire to sleep. Hypomania is milder than mania and have kind of it's not that severe, it's less severe, but again everything is similar, but the energy that they experience is It's like if manics are peak, then hypomanics are a little lower in the uh, peak or in the symptoms. All right, negative symptoms. Negative symptoms are flat affect, social withdrawal, reduced motivation, flat affect. Now this is linked with the affect we covered here. Now I assume and hope that you can understand flat affect means an expression, kind of a no expression face. It's like a blank face without any expression. Social withdrawal, when you're cutted from the interactions and you're not interacting with others, you're socially withdrawn, you're not participating in any social activities, and you also have reduced motivation. So these are the negative symptoms. Sometimes negative symptoms are assumed with bad behavior. It's like, oh, they are so rude. They have a flat face or flat effect on their face, so that means they are so rude and they're not, sensitive. But that's not the case. They actually cannot show their emotions or do not know how to show their emotions or express their emotions on their face. Section 3 is diagnostic terminology. All right, so the first one in diagnostic terminology is differential diagnosis. That's very commonly mentioned in DSM, but students get really confused about what differential diagnosis genuinely mean. It's basically in the simplest way we can say that it's the alternative explanation considered before diagnosis. It's like the person's symptoms are the symptoms that we are noticing in the person can be depression, can be bipolar disorder, can be anxiety, can be etc. And then we try to consider alternate options, and then we try to see the symptoms fall under which one the most. And that is not based on assumption. That the diagnosis has to be based on assessment, obviously, but we are not covering that here in this video. Choosing diagnosis too quickly is not fine. Differential diagnosis is there to help you to identify, oh, there are multiple possibilities or multiple things that this person can be having as a diagnosis. So you try to assess them properly through tools to finally choose, oh, this one is actually occurring with the patient. Next is comorbidity. Again, this is also commonly known and understood through DSM, but as I noticed that some students still experience to understand, like difficulty to understand this. So it's the two or more disorders together. It's like sometimes the person is depressed, but they also have panic symptoms, panic attack symptoms. So the panic attack is comorbid with the depression. Comorbid means coexisting, existing together. So two or more disorders can be existing together. But again, what one mistake usually psychologists or beginner psychologists can do is that they try to treat both the disorders as the whole set of one symptoms as one disorder, and they try to treat it that way. But no, you have to deal with depression as a psychologist separately, and with the other one separately. You have to use specific strategies for each to manage it for the patient. Next is rule out. Rule out is a term that is used when you're considering a diagnosis, but it's not yet confirmed. So it's like we're at this stage of differential diagnosis. You considered multiple options, but then you're ruling out that, okay, this one rules out because the symptoms are very similar to this. And then you mentioned that rule out bipolar disorder. Formulation is the next term, and that's very important. Now you notice that it's going in stages. Whenever we are doing a diagnosis, we have to first consider differential diagnosis, and after proper assessment and noticing any comorbidities or comorbid symptoms existing in the patient, then we rule out one disorder and then we confirm it from the assessment for the formulation. Formulation includes predisposing factors, precipitating factors, perpetuating factors, and protective factors. It's sometimes also called as 4Ps uh, of formulation. And I will try to make a separate video for this one because it's quite detailed and I cannot explain it here. Okay, so never confuse formulation with diagnosis because diagnosis is different. Formulation is very much more detailed about how you see that what really made this disorder in the person. What are the factors that has caused or that has developed this disorder in a person? And while diagnosis itself is the name of the disorder. Next is the prognosis. It's the expected future. Like, what do we expect? It's mainly about the recovery. How long do we expect that the person will take in the recovery, or what is their progress? And based on their progress, current progress, how do we see them going ahead? So that's your prognosis. When a patient is adhering or following the treatment plan and following everything that he's being asked, then it's expected that there is a good future outcome or good prognosis for them. Then next is therapy terminology. I could have made a separate video for each element, but I wanted to keep it comprehensive to cover all in one for you so that you do not feel hassle of finding each separately. All right, so therapy terminology first is repo. I'm not going to explain this one because mostly you know that repo is about building trust with the in a therapeutic relationship with the client. Okay, next is resistance. Resistance is sometimes misunderstood and it's noticed as defiance, that the patient is stubborn and defiant and they do not want to give in for the treatment. But resistance is actually the barrier to the therapeutic change. And it's like sometimes a person is trying to avoid discussion of painful topics that resists them or stops them for the therapeutic change. So resistance is due to some discomfort that they experience when they have to talk about a therapeutic change. Next is transference. Again, this concept comes from Freud's concept, transference and countertransference. And client projects feelings from past relationships onto the therapist. For example, if they had a polite friend and they start seeing that in a therapist, in their current therapist, then that's transference, that they're transferring their past experiences or relationships onto the therapist. Counter-transference is the opposite, that is from the side of the therapist. Like if you see someone and you, for example, if a psychologist have lost their father and an old patient comes and they feel that he has similar habits as their father, so they sometimes start to react in emotional ways towards the patient. That's counter-transference. Therapeutic alliance. Okay, therapeutic alliance is collaborative working relationship. It's like you and your client or patient are in therapeutic alliance and you're collaboratively working with each other to bring the therapeutic change. All right. So we have covered a lot. It's quite overwhelming to see this much information. But again, you can just do it in slow chunks. It's not important to do it all in one. But even if you do it, try to make notes sideways. That will help you to review it later and use it practically for your internships. All right, hospital terminology. Referral, you must have heard about it. It's a general term that tells that we have, for example, a psychologist receives a referral from a psychiatrist and they say, oh, it's a psychological case. So that's the referral that the patient is referred from one assessment or treatment to the other process. Admission, that's very basic. I'm just skipping this one. It's like admitting the patient. Discharge, again, it's the very basic terminology for hospital where the patient is being discharged or they are being removed from the inpatient services of the hospital. Consultation. Consultation, you already know, it's like a one-on-one kind of session with a doctor, with a psychiatrist, and they consult to get a professional opinion. MDT, that we will also cover in the abbreviations. It's like multidisciplinary team. Whenever you work in a clinic, you will get to or hospital, you will get to see nurse there, psychiatrist there, or co psychologists and other internees. So that's a multidisciplinary kind of team where there are multiple professionals. All right. So hospital terminology ends here. I will include about medication terminology. Medication terminology, compliance, that the patient is following the treatment instructions. They are listening to us. That's compliance. Adherence, they are listening to us is compliance. Adherence, that they are following whatever is being asked and they are collaborative for bringing the change through treatment. Side effects, you must be already aware. It's like the side effects of psychotropic medications or the medication effects. PRN, this is very commonly used in abbreviations in documents as well. And PRN means needed or a required medicine or a treatment course. Polypharmacy, multiple medications simultaneously. Now, why am I telling you the medical terms when you are a psychologist? Because psychologists just talk about delusions, hallucinations, DSM language and all that. But no, for being a professional, you do not work alone. You work with other team members to bring the most effective change for your patient, who's the center. Everyone works together in interaction. And this actually, to interact with other people, it's like if you're in a university where everyone talks English and you don't know English, you don't know the language, then you won't be able to express your ideas in a way that they understand, or you can't understand their ideas that they are trying to express. So knowing each other's language is really important for a professional life and for a successful professional career. So polypharmacy means multiple medications simultaneously. All right, so assessment terminology. I'm not preferring to turn the page because I really want to cover similar things on the same page. So I'm going in this corner. I hope it's clearly visible. Assessment terminology includes screening. Screening is the initial evaluation. You can say the basic identification of the possible issues. What can be causing them to come here? What is the reason that they are visiting you? So that's screening, trying to identify the basic issue, the possible issue. So what could be causing their problems? The basic identification. Assessment is the more formal identification or evaluation of their problem. So screening is like you got the data to choose your assessment plan, and then assessment is the formal evaluation of the patient. Baseline is the initial, for example, you have done the start assessment and you have got the baseline. Oh, now I have got a direction, and this could be the disorder of the patient. So that's the baseline. Validity measures what it claims. Validity is similar to the concept that we talk in the research methods as well. And again, reliability, this is proved when you try to use a battery of assessments on the patient, that you don't say, oh, I just applied DAS on the person, and based on the scores, I assume that this person has depression. No, you have to apply multiple tools, because we can't rely on one tool. We have to apply multiple tools to actually diagnose the person as depression. And those tools are not always just the questionnaires. It can be your mental state examination, your observation, the record you get from the family, and everything. All right, documentation terms. This is the last one in the terminology, so just relax. I'm not filling the page after this one. Okay, so here we go for the last terms. Progress notes. Documentation, if these terminologies are helpful when you're trying to document, or you're asked to write notes for the patient in every session. So documentation abbreviations or documentation terms are really helpful. Progress notes are updates after session, like what you noticed, where was the patient in the last session, what progress did he have so far in this session. So these are the progress notes that are the updates of the session. Case notes are the clinical records. It's like the symptoms you have been observing in the patient when you're observing them in multiple settings, like group session or morning meetings and all that. Follow-up is review after intervention. For example, if an OPD patient, outpatient, who's not hospitalized or admitted, just visiting. So if you suggested them to work on an intervention and they come back, that's the follow-up. Now you will see how has that intervention helped them to improve. SOAP notes. SOAP notes are subjective, objective assessment and plan. Subjective, objective assessment and plan. And these are the notes, basic notes that you have. What are the most specific things that you want to plan for this patient? What are the general things that you plan for a patient with this disorder or similar disorder? What is the assessment that you further require to confirm a few more things? And what is the further treatment plan that you want to follow up? So it's kind of a general overview of what you're thinking for ahead for the next session. All right, for the 100 practical clinical terms that students should know, I am going to attach a document for you, a downloadable PDF document, and that will be really useful to know all these terms, the 100 practical clinical terms that you can go through on your own in your time. But some of them I have highlighted here that I thought were really different and somehow very professional and important. So one is crisis intervention. It's like the immediate support response. If someone comes, a suicide case comes, so the immediate support response that you do is the crisis intervention. Clinical impression is your professional judgment. One judgment is that neighbor auntie would make on you. That's not a clinical impression. Clinical impression is your professional judgment as a professional. And that is based on obviously your logical explanation of the symptoms you noticed and your language of DSM and IDM. Titration is a gradual dose adjustment. When a psychiatrist gradually adjusts the dose, it can be that they are increasing the dose or decreasing the dose based on improvement or disimprovement in a patient. So titration is that. Sedation, that when initially a patient is admitted, especially the drug abusers, they are sedated if they have hallucinations and such severe things. And in that situation, you cannot take their sessions. So sedation is the medication induced calmness. It's preferred not to take their sessions or not to rely on the information they provide during their sedated period. Chief complaint is the main presenting concern of the patient, and this is kind of the starting point for you to begin the whole process of treatment with them. All right, I have also written some of the abbreviations that you can use in your records or files, or if you're a new internee and you're trying to review the old files, and these abbreviations can be you can see them there, and understanding them can be really useful for you to read the document or the data that's already there. So the first one that you might be already aware of is the mental state examination. Then SI is for suicidal ideation, HI is for homicidal ideation, AVH it's for auditory verbal hallucinations, DX it's like a short form of diagnosis. This is the short form of therapy or treatment. This is a short form of history. Like if there is a heading like this, that means they have noted history of that patient under that. PMH. PMH is it's the past. PMH is the past medical history. Then FH is the family history. PRN, as I already shared, it's the as needed or as required, and it's usually used for medication description, description of medication. Then this one, SX, is for the short form for symptoms. FU is for short form for follow up. Now this is normally never shared with students of psychology, but I would say that being a medical practitioner, internationally, you or your profession is recognized in medical practitioner profession or medical profession, and for that you need to know the doses that are normally given to patients for psychotropics. OD, when a medicine, any medicine quotes OD with it, that means this medicine is prescribed for once a day. BD is prescribed for twice a day, and TDS is prescribed for 3 times a day. All right, so before we finish, I want you to remember something. If you are a psychology student, an intern, or a fresh graduate, it is completely normal to feel overwhelmed when you enter a hospital, psychiatric clinic, rehabilitation center, or counseling setting for the first time. Most students think their biggest challenge will be of working with the client or with the patient, but in reality, one of the first challenges is learning the language of clinical practice. And honestly, quoting my own experience, when I started my internship, I saw people, even I was embarrassed for not understanding terminologies of psychiatrists or other doctors, and that was actually not a good start for me, and I got emotionally very drained and down. And I am this video. The purpose of making this video is that what I experienced in the start of my career, I want you to not go through that, and I want you to be well prepared before you enter. But even if you watch this video and if you're well prepared, little anxiety is really a normal thing. And the good news is that every experienced psychologist, therapist, counselor, and psychiatrist once stood exactly where you are standing today. Nobody starts their career knowing all of these terms. Clinical competence develops as one case, one session, one supervision meeting. So it's like take one step at a time and just notice and appreciate your progress. You had done a great and a wonderful job in finally arriving where you are at today, because most of the students have just started their journey of the degree, but you're already at the period where you're almost finishing it. So that's already beautiful in itself. So appreciate yourself always for the small things that you do, and those small things are really big, not small. Maybe in your eyes, but someone does think they are big, quite big. If you're watching this video till the end, I want to just give a teaser for my next video that I will be uploading soon. And that is going to be about how to sound professional and how to increase your confidence. And it will cover advanced clinical terminologies. It's kind of a level up after this video. One more thing for all the listeners who had been listening till this far, I really appreciate you guys watching it. And I want to share one last thing with you, that a good psychology student might know theories, a competent clinician understand people, but a successful clinical psychologist learns to speak the language of practice. And that actually really matters. And it would be great. I really want to, and I would love to hear from you in the comments about anything that out of this list is confusing for you. And just share it in the comments, and I will just look into it to see how I can help you even more. Thank you so much for watching so far, and good luck for your internships or your start of the career. I am sure you're going to do great. It's just a matter of you have to first start believing in yourself. So good luck. I believe in you if you believe in yourself. Thanks for watching. Keep watching, keep supporting.